So as we start to move into the lifetime management of aortic stenosis, and we start seeing people move TAVR to younger and lower risk patients, we have to think more and more about structural valve durability, and in fact, overall valve dysfunction. But structural valve durability is something that we as surgeons have thought about for a long, long time. So we decided to look at the 5-year incidence, outcomes, and predictors of structural valve deterioration of the transcatheter and surgical valve bioprosthesis, and we use the high risk and the intermediate risk randomized clinical trials and continue to access trials for the core valve Evolute. These are my conflicts of interest. I mean, I've been on the executive committee of all these core valve trials. I was the national PI in SVD TAVI and low risk, so I've been very much involved with them. But then again, I've run the trials for Abbott and Boston Scientific and Gore Medical also. So my conflicts kind of span across those. So transcatheter valve implantation is a well-established treatment for severe stenosis in patients at all risk levels now. We do have different guidelines in the US and in Europe. Our guidelines say less than 65 surgery. Your guidelines say less than 75 in low-risk surgery. But durability is something that's important for both these guidelines. We're now seeing younger, low-risk patients with increasingly long expected survivals being sent to us and being offered TAVI. So lifetime management of these patients really requires us to have a strong understanding of bioprosthetic valve durability and failure, both for TAVR valves and for surgical valves. The VARC3 and the European consensus documents really define 4 modes of bioprosthetic valve dysfunction: structural valve deterioration, something wrong with the valve; non-structural valve dysfunction, something wrong around the valve; thrombosis; and endocarditis. However, there's really limited data on the incidence and factors associated with structural valve deterioration after TAVI and surgery from large-scale, multi-center, randomized clinical trials. Some previous work with the prior generation balloon expandable valves, which was published by Peeborough, showed that for the XT and the Partner 2A trial at 5 years, there was more structural valve deterioration, 9.5% versus 3.5%. Now, if you went into the non-randomized propensity matched S3 group, the difference was 3.9 versus 3.5%. So that was no difference. This was actually considered a win if TAVR could stay up with surgery. If you read further in the printed article, if you go to the supplement, what you find is if you do inverse treatment probability matching, which removes the tails, that actually for S3, there was more structural valve deterioration in years 4 and 5. And that wasn't really highlighted in this, but this was considered a win. Now, we'd had a prior analysis with the core valve and Evolute supraannular self-expanding valve and found significantly lower 5-year rates of hemodynamic valve deterioration or reintervention due to stenosis in a prior trial. So what we wanted to do is go back and do an expanded evaluation of the 5-year incidence, outcomes, and predictors of structural valve deterioration in these patients. Now, the way we did this is we took the randomized portion of the high-risk and SVD TAVI trials, it's over 2,000 patients, and used the randomized patients to compare the rates of structural valve deterioration. Then we added in the non-randomized continued access patients, which gets us to over 4,700 patients, and used those to look at clinical outcomes and predictors of structural valve deterioration. Now, we basically based this on VARC3 definitions, and our definition was a moderate or greater structural valve deterioration was an increase in the mean gradient of 10 millimeters of mercury or more from the discharge of 30-day echo to the last available echo, and a final mean gradient of 20 millimeters of mercury or more on that last echo. Or you can have a new increase or onset of intraprosthetic valvular regurgitation of moderate or greater. All the randomized stuff was looked at by an independent core lab, JO, in the Mayo Clinic. And in fact, all of these were reviewed by myself, Kendra Grubb, and Steve Yakubov, along with JO and Saki Ito, who is his assistant up at Mayo. We looked at the 5-year cumulative incidence of structural valve deterioration and calculated it from the randomized cohorts using a fine-grained regression interval censoring, and we treated death as a competing risk. We found out a long time ago in surgery that you couldn't just do a Kaplan-Meier, you had to use death as a competing risk. Remember that the high risk had a mean age of 84, intermediate risk had a mean age of of 81, and death was a big part of these. High risk had about a 50% mortality at 5 years, intermediate risk about 30%. So you had to have death as a competing risk. We use univariate Cox proportional hazard models to examine the association of structural valve obturation as a time-dependent covariate with clinical outcomes of all-cause mortality, cardiovascular mortality, and hospitalization for aortic valve disease or worsening heart failure. And the baseline characteristics that were associated with structural valve obturation were identified using both univariate and multivariate fine-grained regression for interval sensing analysis, and again, treating death as a competing risk. Now, if you look at the demographics, what you see for surgery and TAVR in the randomized portion is that basically they match up, just as you would expect for a randomized trial. But when you look for TAVI in the non-randomized part, the continued access, you see they're older, they have a higher STS, and they have more comorbidities. So what do we find? What we found at 5 years was that the structural valve obturation for surgery of moderate or greater was 4.38%, and for TAVR it was 2.57%. And that was significantly in favor of TAVR. Now, this is really somewhat of a surprising finding because as surgeons, we've already said if everything's equal, you got to use surgery because we have the durability data. And this is really kind of the first time where it said, well, maybe based on these definitions, TAVI may have more durability than surgery. We also looked at a small annulus, which defined as an annulus of 23 millimeters or less based on your CT scan. And what we found was the rate for surgery was 5.86%, and for TAVR was 1.39%, again, statistically in favor of TAVR, but you see it with a widening gap. And that's really not a surprise. We've known with the self-expanding supraannular valve, as you go from a small to a large annulus, we don't see an increase in patient prosthetic mismatch. But in surgery, we see patient prosthetic mismatch start to soar. We then look for large annulus, 23 or greater, and what we see is 3.96 versus 2.48. That's no longer statistically significant, mainly based on numbers. But again, you can see that it's trending in favor of TAVR. Most of these you can see are related to stenosis. Very few of these are related to regurgitation. And there is more moderate than there were severe, but there is a fair amount of severe structural valve deterioration. And this to me is the money slide. If you develop moderate or greater structural valve deterioration, whether you had TAVI or whether you had surgery, it basically doubled your risk of all-cause mortality, doubled your risk of cardiovascular mortality, and doubled your risk of hospitalization for worsening heart failure or aortic valve disease. As you notice, the only thing that crosses unity is hospitalization for AV valve disease in the surgery alone randomized cohort. This is probably just based on numbers. Otherwise, all these are statistically significant. So this is really an interesting finding because we not only have shown a difference, but we've also shown a clinical outcome based on our definition, which doesn't include the VARC addition of either an EOA or a Doppler velocity index. We, of course, went back and did this using the full VARC, which required a shrinking of your EOA or decrease in your Doppler velocity index. And we lost about 20% of the data because not everybody had that. And this still all trended in the same direction. It just had less patients and started to lose statistical significance because of smaller numbers. I do think this shows that you really don't necessarily need those two data points to have clinical significance. And that's why we develop these definitions, really to associate them with clinical significance. So what are the baseline characteristics of who did and did not get structural valve deterioration? Those that did not get structural valve deterioration were older, more often male, and more often had a prior PCI or prior atrial fibrillation. And that should be no surprise to us. We've known for decades as surgeons that the older you are when we put in a bioprosthetic valve, the longer the valve lasts. No surprise. Shouldn't surprise us that they have more comorbidities because they have more death, so they're going to have less structural valve deterioration. They die before they get it. It shouldn't be surprising that less males get it than females because males are bigger and they start off with bigger valves. The bigger the valve you start off with, typically the better you do. And it really shouldn't surprise us that PCI and atrial fibrillation are associated with less structural valve deterioration because those are both markers for cardiac disease, which cause you to die more often. And remember, death, particularly in this elderly population, is really a competing risk. So again, males, older, atrial fibrillation, and prior PCI. Who didn't get it? Larger patients. Who got it more often? Larger patients got it more often. Now, the converse of this, of course, is that if you're a younger, healthier female, you're more likely to get structural valve deterioration. There were a number of limitations with this study, as there are with all studies. The current follow-up is limited to 5 years. There'll be a 10-year follow-up of TAVI and a 10-year follow-up of the low-risk randomized trials. And of course, with the low-risk trials, we'll present this same data. We just presented the 3-year outcome for the low-risk trial, and we saw that the primary endpoint of all-cause mortality disabling stroke, which had a delta in favor of TAVR of 1.8 at 30 days in 1 year, moved to 2% at 2 years, and 2.9% at 3 years. So we actually see in the low-risk trial with this valve, the survival and the primary endpoint are both increasing in favor of TAVR. I won't have the 5-year data for about another year. It'll probably be ACC 2024, maybe, but unfortunately, maybe even a little later than that. Hopefully, we're going to see the 5-year PARTNER 3 data at TCT this year. The contemporary data for structural valve deterioration requires a prospective collection of comprehensive echo parameters. In current studies, as I noted, there was incomplete collection of EOA and DVI, which are required in the full VAR3. And we restricted this analysis to gradients and AR severity alone. But again, we showed very good correlation with clinical outcomes. And the correlates with invasive gradients were not collected in the study, but again, 5-year outcomes were pretty compelling. And the competing risk of mortality limited the number of patients with structural valve deterioration, similar to what we've seen in our prior surgical trials. So in conclusion, we concluded that patients with severe AS and intermediate high-risk trial, the 5-year rate of structural valve deterioration was significantly lower in TAVR than it was in surgery. And the difference was more profound in patients with smaller annuli, but there was still a trend with larger annuli in favor of TAVR. And this Doppler-derived structural valve deterioration definition imparted a doubling of your mortality and doubling of your rehospitalization. And the multivariate predictor analysis found a higher risk of developing this in patients with a higher BSA and lower in men, older patients, those with prior PCI or atrial fibrillation. Now, there are some clinical implications. The core valve evolute suprannular self-expanding bioprosthesis is now the only bioprosthesis to demonstrate lower rates of structural valve deterioration compared to surgery in randomized trials. This was also seen at 8 years in the NOTION trial. In April of this year, the last NOTION patient passed 10 years. So hopefully in the next year, or less than next year, we should see the 10-year data out of NOTION. This is also only a valve that at every time point tested in a randomized trial has had superior hemodynamics to surgery. In PARTNER 3 surgery, we actually beat the SAPIEN 3 valve for hemodynamics. And that serial Doppler is a valuable tool to monitor patients after TAVR with changes in gradients greater than 10 millimeters of mercury and a persistent elevation of 20 or more, or the development of moderate greater intraprosthetic AR at 5 years, identified a subset of patients that had a twofold increase in death or hospitalization for AV disease or worsening heart failure. And long-term follow-up is ongoing. Valve durability should be really an important consideration when we start thinking about the first valve we choose for patients. And that was the presentation that I gave at ACC. We've since done a presentation on full valve dysfunction. Steve Yakubov gave that, and that presentation is currently manuscript is currently in preparation. And let me unshare. And I am happy to discuss this with Patrick or anybody who wants to talk about it.
Well, thank you for the outstanding presentation as usual. Maybe if someone from the Leipzig team had any questions to start off with.
Oh, well, Michael is there as well. I think he wants to.
Michael, you're on
Hi,
mute.
Michael.
You're on mute, Michael.
Hi, Patrick. Sorry, hi, Patrick. Hi, Michael. Sorry, I joined a bit late. I think we'll leave our questions until after Patrick has made his commentary, and then because there's lots to discuss here. Then, so Patrick, if you want, just go ahead.
Yeah. Okay. Sure. I also just prepared a few questions with data from the manuscript in a presentation. Maybe I'll try sharing that. But while I do that, just Michael, outstanding study and really compelling data for TAVI. obviously it's an outstanding technology that completely changed our practices, and we're able to treat so many patients with TAVI now. The big question is the lower risk patients. Where should we be going? Where should limits be? And each time we have guidelines coming up, it's always quite a big challenge in the discussions. The questions I had, something I remember very well from EACTS 2019. I think you were in a panel, a roundtable discussion, and as the PI of all these trials, I remember you very well saying that you design a trial to get the result that you want in a way. Of course, that seems obvious, but there are a few questions in how different things were defined in this in these series. The first was the definitions for structural valve deterioration. Now, the VARC3 definitions are really quite detailed and really improve research in aortic valve interventions. Let's say that if we look, this is a very busy illustration from the VARC3 paper, which is how they define bioprosthetic valve dysfunction. And going on to the next thing, the actual criteria for structural valve deterioration are really quite vague. It's only afterwards if there are hemodynamic consequences, which they divide into different stages, moderate, severe, which come back to the different elements that you used in this trial, or in this study. And then if there are clinical consequences, they will define that as bioprosthetic valve dysfunction or failure, sorry. So using what you used was essentially the moderate stage of hemodynamic valve deterioration. I wonder if this doesn't skew it slightly towards having more events, and so you're more likely to find a positive finding in one group or the other. Now, of course, you showed very elegantly, looking at both the moderate stage hemodynamic valve deterioration and the severe stage, that both have a let's say an impact on mortality, on survival of patients. So even if we can question whether these are the right definitions to use, it has a prognostic significance. So it most likely is quite important. Let's say a more fundamental issue to all these trials, and that we saw also in Notion, is that the valves that are used in the surgery that's performed is very heterogeneous. We're comparing a very controlled, a very well identified TAVI valve, but on the other hand, we're using a whole slew of different surgical valves. And if we just look here, the microflow and trifecta valves, now it's easy to say in hindsight that those are pretty lousy valves that don't perform well over time, that have quite a lot more early SVD, and that we're seeing coming back for early replacement. But having close to 30% of these types of valves in this group, it seems like the comparator in the surgical arm is going to be, let's say, just looking at it prior without looking at the results, I would expect them to not do too well. The other issue is the size of the valves. We've got 36% of the valves that are 21 or smaller. Now we know, and as you've shown in your data, that smaller annuli don't do well over time. I think in another paper we're looking at not structural valve deterioration, but mismatch, that in the core valve and Evolute trials, there's up to 30% mismatch in the surgical patients. So that's obviously, as surgeons, we're not doing our job of getting the patient out with a low gradient with a good valve that will last a long time. So that's just a comment on the surgical arm, that perhaps we have not the ideal situation for the surgery that's being performed, while we're being extremely selective in the centers that can participate in the TAVI arm, and to have operators that are highly trained and will hopefully get an optimal result. The last issue is on the follow-up. So it's great to be getting more and more data with long-term follow-up, and of course, as you said very well in your introduction, that we've always thought that SAVR had the advantage of long-term follow-up. Now, obviously, the core valve and Evolut platforms have outstanding hemodynamics. What I'm just wondering is, from a methodological standpoint, here there's a little note between 3 and 4 years that we see these curves have a slightly, although they're perfectly stable the rest of the time, between 3 and 4 years, suddenly they seem to differ a little bit in terms of the EOAs, not so much in terms of the gradient on the right side. And we see in that little note that for these periods, it was not using the core lab assessment, but in local self-reported echo readings. So maybe a little bit of comparing not exactly comparable items at these different time points. And the last thing is looking at the Kaplan-Meier curves. We need the number at risk. We need to know how many patients have been followed up to 5 years, because if we have attrition, perhaps the analysis at the later dates where we have very big gaps after the 4-year point, it seems like perhaps we don't have that many patients who are still at risk. And maybe the big difference is, although obviously the curves are quite different starting off between the 1 and 2 years, it does seem like that difference seems to accentuate itself in later follow-up. And if we're losing patients to follow-up, maybe we're not getting a full picture of what's happening. We do get some information, although obviously it's just the echo data from the previous figures that you had put in the manuscript, that at 5 years, we've lost, in terms of the gradients, there's only 405 patients in the surgical arm out of 966 who had echo data. And since that goes into your calculation of SVD, I would assume that means that at the end of the Kaplan-Meier curves and follow-up, we have quite a few patients who are missing, or who have not been followed up.
They're dead.
They're dead. Okay, so that's okay. The competing risk issue. Okay, so those were just a few questions and comments, and really, congratulations on some outstanding data and pushing us as surgeons to do a better job in the operating room.
Well, listen, first of all, I agree with everything that you brought up. So we did we did not just moderate, we also did the severe, which was an increase of 20 or more, 30 or more, as the final. We didn't include EOA or DVI just because we didn't have it. We collect all those in my institution, but not all of the institutions did. You're right, at year 4, 3, and 4, we didn't have core lab. We had 1, 2, and 5 for core lab. So you could actually, leave those out if you wanted to. The drop off, of course, was the people that were dying. Now, the surgical valves are very interesting. I fully agree with you on that. A couple of things. First of all, the amount of annular enlargements done in this trial was about 5%. In my current practice, using the Y annuloplasty, I do annular enlargements in a little over 40% of my patients. I've actually told Medtronic if we could run this again, I think I could win. And guess what? They don't want to run it again because people set up trials and they set up trials to win. Now, I'm not saying that they're cheating. I'm just saying that they have a conscious setup to choose endpoints that they think they're going to do okay at, and then that's what they do. I wrote my first paper on trifecta failures in 2017. I wouldn't use a trifecta in this trial. The problem was I couldn't dictate to surgeons what valve to use. You could dictate what TAVR valve, because that's the only way they got in the trial. But imagine going to your fellow surgeon and say, I demand you use this valve. You might imagine my fellow surgeons were not keen on that. But the mitral flow and trifecta, those are failure valves. And that was at least a little over a quarter of them. And again, I wrote about that initially in 2017. We haven't had them on our shelves for a long time. One big reason why you develop early structural valve durations, if you start with a small EOA. And if you start with a small EOA, you have less runway to develop stenotic valves. And so, I think, again, if we could put in bigger valves, because, having that many 21s, 21 and 19, I will not put a 21 or 19 into anybody. Okay? My smallest in a woman is a 23. My smallest in a man is a 25. We do a CT on everybody. I do an area-derived diameter. I pick a valve that matches that. That's the way we do it now. But again, a lot of that comes from Bo Yang's Y annuloplasty, which I find a lot more helpful in getting bigger valves in than just a Nix or a Manugia. And then lastly, we talk about the way these trials are run. remember, everybody is seen by local heart team, and the local heart team says they have the inclusion criteria, no exclusion criteria, and their anatomy is good both for the TAVR valve chosen and the surgical valve. So one would think when it goes to a national screening committee, basically everybody, other than maybe a few people that would have measurement errors, would be accepted, right? So how many people in the partner trial were turned down at the national level? You want to guess it for me, Patrick? How many?
I don't know, something like 50%.
34%. 34%. So 1/3 of the patients which were deemed adequate at the local side, and in Evolut, it was 14.8%. So again, as surgeons, we need to know this data because, if you just tell the cardiologist, say, well, listen, the lowest trials were positive, we know, so TAVR works. Well, wait a minute, if you're turning down, first of all, not only do you exclude a whole bunch of people, you exclude bicuspid valves, you exclude associated procedures, you're excluding all this stuff, excessive LVOT calcium, and then you exclude another third when they hit the national screening committee. These are not all comers. And so, listen, I'm a big fan of TAVR and the right people, but I think as surgeons, one of the things we need to learn is not so much this data, but I have another lecture on who wasn't treated in the trial, because randomized controlled trials only apply to populations similar to what's tested. And most of what I'm seeing in my clinic don't fit these trials. I mean, the number of people less than 65 in these trials was about 60% in one and 7% in the other. And I ran screening in Evolut. If you were less than 65, you weren't a normal less than 65 getting into this trial. And I have people sent to me now that are 50 and they're told they're going to get a TAVR. And I have to tell them, nope, you're not going to get a TAVR. You're going to get an operation. So anyway, I agree with every single one of your points. I think this is very interesting data. To me, the most interesting data is going to be the low risk data. Because in low risk, we're going to have some real survivors out at 10 years. And that's going to really tell us. Because, when you're 81 years old and the intermediate risk and 84 and the high risk, if we're doing surgery on these people, we're not expecting them to come back with a valve failure unless they get endocarditis.
Absolutely. Well, thank you very much for your thoughtful responses. And obviously, the questions are just for discussion. And I'm a big fan of all the work that you are doing, and running these trials is incredibly difficult. I know that very well. So thanks for.
Well, listen, I
spearheading all this.
Questions, because those are real questions that I think we as surgeons need to kind of understand the answers to. Because again, our cardiology colleagues are going to come to us and say, these trials are positive, we should just be doing TAVR in everybody. And the answer is, in the right people, TAVR is a wonderful technological development. But we need to be able, as surgeons, to define what are the right people. So when somebody comes into your clinic and they've been told by the outside cardiologist that they can get a TAVR, and you look at them and they're not a candidate, you can't just say, well, I need to operate on you, because they'll just think you're just trying to operate. You need to say, you need an operation because of this, and lay out the data for them.
Maybe I can jump in at this point then, Michael, just to second also what Patrick said. Congratulations, and we take our hat off to all the hard work that you've done on these incredible trials that have informed so much of our decision making nowadays. But just to reiterate one point that Patrick made, 36% that get a 19 or 21 valve. This is the problem with industry-sponsored trials. They look very closely. They're very careful. They turn down a lot of patients based on anatomy just for TAVR, but for SAVR, they say, well, just you guys do whatever the hell you want, and therefore the onus is upon us who are starting the trials for the future to say, hey, look, we need to encourage people to use the biggest valve possible. I agree with you. You can't tell surgeons which valve to put in, but with Partner 3, they did manage to get much larger valves in, and they reversed the hemodynamic benefit that TAVR had compared to SAVR in the Partner 3 trial. And that sort of goes by the wayside on some of these trials. What also goes by the wayside, and the Integrity Group published this recently in Circulation. Matteo, our Marin-Cuartas here who organized the Journal Club, is part of that group. And they quite clearly showed that there were multiple methods in which TAVR versus SAVR trials were set up, that there was inherent bias in multiple different ways, including deviations from protocol that were much more common in the surgery group. So much more often they got concomitant CABG or concomitant aortic valve, ascending aortic replacement, etc. And that needs to be put in the protocol from the very beginning. Concomitant procedures are out, or if you are going to do them, then you have to decide beforehand that the patient will also get their PCI if they get randomized to TAVR, and the operator has to be committed to doing the PCI rather than just saying, oh, we did the TAVR and oh, it was a little bit difficult and we'll just drop the PCI. So those are issues that we, for future trials, have to be very cognizant and aware of when we're planning these. The unfortunate thing is, though, that this data will be pushed very hard within the guideline committees, and that's also then where the onus is upon people on these committees to be able to interpret the data well, and not just necessarily looking at, favorable primary outcomes, that people actually look deep into the data and the nuances of it. But I had a question also. You recently published a paper, a very critical paper of TAVR practice in the United States right now, together with your cardiologist in JAMA Open, I think it was, and or JAMA Cardiology.
Cardiology.
And yeah, and
Craig just sent me a congratulations for beating him back. So if I've got Craig on my yes, I'm in good shape.
But you made the very good point that we're experiencing not just indication creep, we're experiencing indication tsunami, that there is a lot of patients that don't qualify formally for the indications, either in the guidelines or from those trials, who are now getting TAVR. And when I talk to my American colleagues, they say, well, look, your cardiologist says to you, look, I want to do this TAVR, can you sign off on this? And they feel compelled because their cardiologist is who they get their patients from. How big of a problem is this, and something that we have to watch out for?
I think it depends on where you are, Michael. It's not a problem for me because I've been at my place for 40 years. And if I say no TAVR, it's no TAVR. But if let's imagine you're a heart surgeon, you've been out 5 years and you're really counting. I've got more cases to do than I can do. I give away more than I do. But if you're just starting and you need your practice, it's hard to turn down your cardiologist if you think that cardiologist is going to quit sending you business. Along with the fact that in a lot of the smaller TAVR programs, the surgeons aren't involved at all. They're just operating. And so the cardiologist says, sign off and take your cut of the TAVR procedure when you just walk by and wave at them. And they go, sure. That's because, we still get, it's a co-surgeon deal. So the surgeons that still get paid for half of the procedure, not much, but you get paid for half the procedure. So it is a real problem. I have a whole lecture and I try to talk to surgeons a lot about this, about, remember that, it has to be similar to the population who wasn't treated lecture. And I go through this very, very carefully, because again, we know we set these trials up. Industry sets them up to win. Of course they do. And I think it's very incumbent upon us as we look at this to point out the knowledge gap. So in low risk and in TAVI, we had a separate arm for those that needed revascularization, which was based on whether the surgeon would revascularize them or not. So if there's a total right and the surgeon's going to do it, they went into the revascularization arm, even though they might not get a CTO if they get a TAVR. And some of my surgeons, would just revascularize even when they weren't in that arm. Now, the protocol said that if your syntax was over 22, you had to have surgery. So in the arm where we revascularized, where people say, well, yeah, you did a revascularization arm and it still was good. What was the mean syntax? It was 7. Syntax of 7 is going to have no input on your mortality. And so we treated no significant coronary disease, even though people would say, well, you treated coronary disease in this trial. We treated minor coronary disease. And I see people sent to me all the time with 3-vessel coronary disease with good distal targets. And they're saying, well, you can get a TAVR because, it was in the trial, the arm were revascularization. But it was a mean syntax of 7. And the majority of cardiologists out there that are doing TAVR in the US, they don't know. They don't have a clue. And the surgeons don't know to educate them or educate the patients. So, I mean.
Well, that gets to my point too, that for these trials, it behooves the surgical principal investigator to be regular contact with the other surgical investigators and say, look, this is not a case where you should be doing coronary bypass surgery, but I just think that this should be counted as a protocol deviation, and there's no way that the patient should be included in the trial, or vice versa. You say, okay, if it is, then they have to be revascularized, regardless whether that's TAVR or SAVR. Sorry, percutaneous or surgical. But the other point, my last point before I throw it open to the residents and fellows and surgeons watching, is I'm really, like you, I'm very, very interested to see what the low risk 5-year data is going to show, because I make this point quite often to my group. You know, transcatheter therapy is generally less invasive, and therefore the early risks are less, but it's also generally less effective. So the risk increase over time, whereas surgery, you have increased risk at the beginning, but it tends to be more effective. And then you have crossing of the curves. And in partner 3, for example, those curves were already together at 2 years. So I'm really, really interested to see what happens in the fall with the 5-year results.
Yeah, so I am too, and that's the interesting thing about the low risk evolute, is that they're actually still expanding. Whereas partner 2A cross 2-year, partner 3 is coming together. We're going to see the 5-year data at TCT. Just a comment on, so all those, when people would do what they weren't supposed to do, Michael, like they'd add on a procedure, those were protocol violations. I talked to every one of those investigators. The problem is I didn't hear about it till after it was done. Surgeons tend to do what surgeons want to do. And so then I would get the call, well, this surgeon did such and such. And I'd have to call and say, that's not the way it works. And he says, well, that's what the patient needed. And it's very hard to go to one of my fellow surgeons and say, that's if that's what they needed, you can't do it. The problem is how you best handle that methodologically in the trial. And I would agree with Matteo in the group that there are some real issues of how we run these trials. There's no question.
That's what I would say to everybody who's watching this right now. The reason we do these trials is because there's equipoise. We don't know what the right answer is. And it's absolutely forbidden that the surgeon in the OR says, oh, you know what? This patient shouldn't get double mammaries because I think they shouldn't get one. No, they have to get a double mammary because they were randomized to double mammaries. And we as surgeons have to learn to do these clinical trials better. So I apologize. I'm going to throw it open, Matteo. Back to you.
Patrick, you raised your hand.
Actually, that's a great segue into the comment that I wanted to make, was about in the ART trial. We saw that it was not very selective in terms of surgeons having a good experience in multi-arterial grafting. And we had a 14% crossover rate, just because likely some surgeons who don't have a huge experience with doing 2 mammaries figured, oh, well, this case is not one that I feel comfortable doing. So let's just do mammary and veins. In the Roma trial, well, our Mario Gaudino, Steve Freens, and the group learned from the errors of ART, and they just published, since they finished recruiting patients, there's a 1.2% crossover rate. So that's showing that if you have very stringent inclusion in terms of operators in surgical trials, you're able to improve the execution of the trial from a surgical standpoint. I think really, Michael, it's a pleasure hearing you, and agree completely with your comments that we need to know this data to go back to our heart teams and be able to discuss them well.
And remember that surgery is technique and TAVR is technology. Technology is easy to learn. Technique, it takes 10,000 hours to be an expert. And so who you choose to do these on the technique side matters a lot. Who you choose to do this on the technology side, and I wouldn't say this publicly, but I could take my wife in and she could do TAVR if I told her what to do. Because she's smart, but she's not anything to do with medicine. But if I told her what to do, blow up the balloon now, twist the handle now while I hold it, we could do that. But there's no way she could do a surgical aortic valve replacement.
Well, there was a tweet that exploded over the weekend in the UK where an NP was operator number 1.
Yes.
The CTMD contacted for comments and so on, but certainly the UK cardiologists are hopping mad about that. So indeed, you can train anybody to do TAVR, and probably why it's developed so well.
Yeah, well, anybody can do it as long as it's easy. It's like an appendectomy. An appendectomy is easy when it's easy. When it's hard, it can kill you.
Absolutely.
Dr. Reardon, I have a question. In this trial, as far as I know, the valve were supraannular, right? So my question is, do you know if there is any data comparing SAVR with intra-annular TAVRs? Because I mean, it's known that supra-annular TAVRs have better gradients. So what about the intra-annular TAVRs, which are
So the intra-annular, the portico valve has not been compared against surgery, and it probably never will be, in any large trial. But we do have data that can compare it against, TAVR versus TAVR. And interestingly enough, the intra-annular portico seems to have hemodynamics that match the supraannular evolute, which match the supraannular accurate. And it seems to be more of a valve design and frame than it does where the valve itself actually sits. But I was the national PI with Lars Sondergaard on the Portico NG trial. I'm now the global chair of the Vantage trial, which is the intermediate and low risk Portico trial. And I spent a lot of time looking at the hemodynamics, and the hemodynamics look very similar. And even if you forget about EOAs, which are kind of hard, look at Doppler velocity index. I'm a big believer in Doppler velocity index because it gets rid of the measurement error of the LVOT. And the Doppler velocity index of the self-expanding valves tend to run about 0.6. The Doppler velocity index of surgical valves in the randomized trials tend to run about 0.5. The Doppler velocity index of the balloon expanded valves tend to run about 0.42. Remember, Doppler velocity index basically is a ratio of that patient's EOA to that patient's LVOT. So it doesn't change as valve size goes up, because as valve size goes up, the LVOT goes up. It's just a ratio, and it's already then indexed for that patient's flow, because it's flow below equal flow above, and it's indexed that patient's size because the ratio of EOA to LVOT. It's not an EOA, but it's a ratio. And what you want is the biggest EOA you can get for your size. And that's what those represent.
Okay, all right. Matthias.
Yeah, Dr. Reardon, thank you so much. It was a fantastic presentation, and a field I'm very, very interested in. And so I have 3 questions for you, short ones, I hope for you to answer. The first one is, how many patients in that trial had a post-TAVR CT somewhere after the procedure? So to kind of look for what the actual cause of the SVD was. So is it thrombosis? Was it, leaflet motion that was impaired? What was it? The second question is, in the trial protocol, did you, or were you able to include the true ID of the valve as a covariate in the analysis? Because that would allow you to get rid of all those discussions about valve size, females, young, different valve types. And the third question is, were you able to do like a landmark analysis where you, let's say, kick out the first 6 months or 12 months and then just look at the year 1 to 5 and see is that still different?
Yeah, well, we didn't do that, Matthias, but my suspicion is if we landmarked it at a year, they would start to parallel. And I think that the reason that the self-expanding valve won over surgery was because it started with a bigger EOA. And if we'd started with equal EOAs, we would probably have equal curves. We don't see these curves diverging, other than early on. And so, again, I think it's how big an initial opening. Now, if we index to the true inner diameter of the valve, then yeah, that would be a great way. We didn't do that, but I think all of us as surgeons understand that when we see a 23 valve, at best it's 21 internal, at best. If we see a 19, it's 16 or 17. It's nothing. And I think that we put in valves that were far too small in these trials. And I think that I've literally told Medtronic this is, why don't we run this again? Because I think I could win this time. And as you might imagine, they're not interested in having me run this again. From the CT standpoint, remember that the intermediate and low risk trials had 4D CTs. And it was after Portico started seeing this halt, the FDA demanded it. And at least the low risk trial had it. Now, halt was kind of a funny thing. When we got our original halt data, we didn't treat anybody with anticoagulation. We just followed them because we wanted to figure out what was going to happen. And there was a fair number that had no halt at 30 days, that had it a year. There were people that had it 30 days and had no treatment. And it was still gone in a year. And we had a hard time figuring it out. If you look at the core lab for the 4D CTs for both Partner 3 and our low risk, were the same core lab. It's Vancouver, Philip Blanque and Jonathan Leipzig. And if you look at the halt of 50% or more, it was more common in more common in TAVR than surgery in the partner trial, more common in surgery in the Evolut trial. But if you look at halt, it's always more common in valves that are made out of bovine pericardium than porcine pericardium because it's thicker. Now, the reason we use bovine pericardium in surgical valves is all the early valve failures were manufacturing issues. And you didn't have to switch it, so you wanted something tougher that you could sew. We could probably move all our surgical valves to bovine pericardium if we wanted to, but we'd have to run it all through, the B Pharma and FDA, and nobody's going to do that. But technically we could do that, and we'd probably have better surgical valves. But anyway, I agree with that. I think indexing to the inner sides would be interesting to do. If you want to do a sub-analysis of that, I'm happy to go to the Medtronic people and say, let's do a sub-analysis. I run the publications committee, so all you have to do is submit, a request. Say, here's the data I want. Here's how I want to do it,
Okay.
and I'd be happy to do it. Again, I believe in TAVR, and the right people. TAVR has been a wonderful thing. I mean, there's people that I've got a guy right now that just got sent to me. He was in Louisiana for a month, a Jehovah's Witness, who's 87 years old, symptomatic severe AS. They screwed around. They tried to do a CT on him. He supposedly had anaphylaxis. They never got any data. And after a month, they sent him to us. Well, now after a week, we finally got a CT. His anatomy is good. He's up out of bed. He's walking around. I'm not going to operate on the guy, but he's going to get a TAVR and he'll go home. And the right people that you and I don't want to operate on, this makes a lot of sense. But I also have a guy that's coming to my clinic today who's 67, has no comorbidities, and he's got this huge bar of calcium hanging down his aortic mitral curtain. And he was seen at one of my outlying hospitals where, he was told, well, you can have a TAVR, and the surgeon just approved it, but they have to come through me. So he has to come down to see me. And when I see him today, I'm gonna have to tell him, no, you need an operation. And the reason you do is you've got this big calcium, you're young, you'll end up with PVL. We'll put a big valve in you. Again, I do annular enlargements in 40% of my cases now. That's not happening out in my periphery though. In my periphery, the annular enlargement rate is about 2%. So, unfortunately across the country, that's what it is. I mean, this most of the US is not Houston, and it is not very centralized, and it's not Leipzig either. So,
well, thank you very much for that. I drop you a line.
Yeah, well, yeah, drop me a line. No, I'm serious. If you're interested in doing it,
Totally, absolutely, yeah.
We'd be happy to look at that. In fact, if any of you are interested in looking at the data, again, I do co-chair publications with John Forrest, and so send me an email. There's a process for sending in a suggestion, and we'll do it.
Cool, thank you.
Antonia, I see you have a question.
Thank you, Matteo. It's not Antonio. Sorry to disappoint. It's Ibrahim. I'm hijacking her laptop. Dr. Reardon, thanks a lot for a very interesting talk and presentation. One question further to Matthias's question regarding indexing the orifice area. Do you have data regarding the patient prosthesis mismatch at the end of the trial, like at discharge, I mean? Because if we're starting off at a bad point, in the surgical arm, it's no wonder that we are leaving at a bad point as well at 5 years.
Yeah, of course, patient prosthetic mismatch is something you walk away from the hospital with. I've had some of my cardiologists say, well, let's figure out what it is at 5 years. And I go, no. When you leave the operating room, either you have it or you don't. It's not something you develop. If you develop it, it's structural valve deterioration. But when you walk out of the operating room or out of the lab, if you're getting your TAVR, you have an EOA and you have your body size. Now the EOA changes a little bit, based on the fact that both after surgery and after TAVR, there's different flow characteristics in 30 days. But by 30 days, either you have it or you don't have it. And it was much more common in surgery than it was in TAVR. And in the low risk trial, at the end of a year, you were 5 times more common to have moderate severe structural valve deterioration in the surgical arm than you were in the TAVR arm. In the PARTNER 3 trial, it was a lot higher. Because again, the Doppler velocity index of a balloon expandable valve is about 0.42. Hang on just a second. Hello, hang on just a second.
Well, thank you. I don't have any questions anymore. Thank you.
Sorry, that's my transfer center. I'm going to hand it off to. Could be another great case coming in.
How are you?
That's okay, Michael. I think we've held you long enough here today, but are there any more burning questions?
Well, I just have a small question. If you still have 2 more minutes,
Sure.
like what about paravalvular leak? Like we all know the long-term consequence of paravalvular leak. Did you evaluate this in the trial? Like, I mean, we talk
No.
about structural valve deterioration, but what about?
Yeah, so no, the paravalvular leak is carefully looked at in paired echoes, and the mortality related to different levels is looked at. I mean, you know, it's really unusual for us to see anything beyond mild paravalvular leak, but still about 20%. And in low risk patients, 20% mild, anything beyond mild is too much, but 20% mild is too much. You know, if you really want to be competitive, we're going to have to get down to 5% mild or less. And you know, now if we're talking about, again, mean age of 84 in high risk, mean age of 81 in intermediate risk, it probably doesn't make a big difference. But if you start talking about 65-year-olds, it's going to make a difference. I mean, if I put a surgical stented valve, whether it's mechanical or tissue in you, you will not live to your normal lifespan. You'll lose years off your life. And the younger you are, the more years you lose. But by the time you reach about 75, we can no longer show that because you die too quick. Well, you know, there's what's 75? That's where Europe draws its guidelines. Because all of a sudden you now quit seeing these, and pacemakers aren't going to make a difference beyond 75. You know, mild paravalvular leak's not going to you're going to die for other reasons first. But as we move to younger people, that is going to make a difference.
Mhm.
But yeah, that's I mean, we have all that data material. I can get that for you. I mean, we have paired data, and there'll be paired data all the way out to 10 years, because that is clearly that and the effect of pacemakers, you know, that'll be looked at very carefully. You know, you see a lot of the early trials, it didn't make any difference. But again, if you're 84 years old, you're going to die of other reasons. But if you're 65 and you get a pacemaker, that is not a benign event. Or if you're a young, healthy 70-year-old guy like me, you know, I don't want to say 60, but if it is, I haven't even hit the 75-year-old European guidelines yet. I'm still in the surgical group.
Yeah.
Well, anyway, Mateus, listen, thank you for asking me. Patrick, thank you for discussing this. Michael, thank you for letting me meet with your team. You know, it's great to talk to the Leipzig team. It's always great to talk to my fellow surgeons. Thank you very much.
Thanks a lot, Michael. We really appreciate you taking the time to do this. That was fantastic. Thanks very much.
My great pleasure, Michael. Okay, guys, thanks.
Bye-bye. Thank you, Pat.
Michael.
Thank you, Dr. Reardon.